I'm Tomotaka Sobue from Osaka University, and today I will talk about overdiagnosis, what we know so far from epidemiological aspect. When we conduct cancer screening, we have to consider both benefit and harms. Most important benefit will be reducing mortality for the targeted site of cancer. For example, when we conduct breast cancer screening, its primary purpose is to reduce breast cancer death. In addition to this, there may be an improvement of QOL because of less invasive treatment for early detected lesions, or reducing medical costs or relief due to true negative. A true negative means those are among those who have no disease and those who are tested as test negatives. So true means they are correctly judged by screening test. On the other hand, there are several harms. Over-diagnosis and treatment is the one, and I will explain in detail after this. An unnecessary diagnostic test due to false positive or treatment delay due to false negative are those who are incorrectly judged by screening. So those are relatively easy to understand for both who provide the screening and those who receive the screening, because this is misjudged. Also, there are maybe some adverse events due to screening test. In general, tests used for screening are relatively safe, so adverse events rarely occur. But for example, when we do colonoscopy as screening test, there may be certain probability for bleeding or penetration. Now I explain what is overdiagnosis, cancer overdiagnosis. This figure shows how cancer will progress from left side to right side. And suppose cancer becomes detectable by screening at this point, then grow, but not having symptoms, and become symptomatic at this point, and usually then go to doctors having diagnosed and have a treatment and cured. And there is some critical point, a critical point for cure, which means the cancer will be curable if it is detected and treated before this point, but not curable after this. If this person has screening before the critical point, he will be successfully treated and cured. Lead time is the duration for early detection from having screening and having symptom, and survival time is from diagnosis to the latest confirmation of living. Surgeon time is the duration from the point becoming detectable to the symptom emerges. If the surgeon time is long, it means cancer grows very slowly. If this person, suppose surgeon time for this person is very long, like this, longer than the remaining lifetime, this cancer never becomes symptomatic while he is living. If this person has screening at this point, cancer will be detected, and this will be called overdiagnosis. If we know whole story about this phenomenon, we can say this is harm. But for the person, health professional who detected this cancer, or for the patient who are detected having cancer, they feel screening successfully detect the cancer at the early stage, and successfully cured, successfully treated, they never feel this is a harmful event. This is the reason why overdiagnosis is difficult to understand. So, cancer overdiagnosis is not meaning the cases that pathologically non-malignant tumor are incorrectly diagnosed as malignant. They are true positive. They are cancer, not false positive cases. If it is determined by growth speed of cancer and individual remaining lifetime. So two components. So different from other harms, there is no incorrect judgment during the process. So it is very difficult to recognize this is harm. And also it is difficult to determine for individual cases whether it is overdiagnosed or not. But why we say cancer overdiagnosis is problematic? It is because based on the fact that cancer incidence increases above the expected level. One example is RCT for cancer screening evaluation, and the other will be time trend for cancer incidence. This is the finding from a randomized control trial called NLST, National Lung Screening Trial, for evaluating helical CT screening for lung cancer compared to chest X-ray. They divided study participants into two groups, low-dose CT group and chest X-ray group, and each has 26,000 population. And they provide CT 3 times, and for X-ray group, it's X-ray 3 times, then followed around 6 years. And this graph showing the cumulative number of lung cancer deaths compared to chest X-ray group, low-dose CT group, showing around 20% reduction of mortality at 6 years. So this is the evidence for reducing lung cancer mortality with having a low-dose CT. Now, this is the same trial finding, and at this time, vertical line indicates cumulative number of lung cancer cases incidence rather than mortality. In this graph, low-dose CT group is showing a greater number of cases than chest X-ray group. But remember, this is a randomized trial, so the cumulative number of lung cancer incidence should be equal for a long time, long-term observation. First 2 or 3 years, it is okay. A greater number of lung cancer cases will be diagnosed for low-dose CT group because more early diagnosed cases. But later it should become equal actually. But this is never become equal. And these type of findings have been observed not only for this trial but also other screening evaluation study, such as PSA for prostate cancer and mammography for breast cancer. And it becomes interpreted as one of the evidence for overdiagnosis. This is observational evidence which shows the time trend of age-specific prostate cancer incidence for 5 countries. So each line shows age-specific incidence rate. As you can see, USA showing a sharp peak around the 1990s when PSA testing became widespread. So there seems to be no rapid change on other risk factors for prostate cancer. Most of the increase will be due to the overdiagnosed cases, which will not be detected if PSA did not exist. This is another example for mammography for breast cancer. In the US, mammography became widespread in 1980s, and all invasive breast cancer increased corresponding mammography diffusion. But actually no change observed for metastatic breast cancer incidence. If the early cancer detected more, we expect advanced cancer will decrease, but it is not happening, just no change. This is another style of showing observational trend for breast cancer incidence by a specific size, tumor size. We observe an increasing trend for smaller tumors, like less than 1 centimeter, and for larger tumors, like over 2 or 3 centimeter, there is somewhat decreasing trend, but not equal magnitude to the increase of smaller tumors. So far we checked overdiagnosis for lung, prostate, and breast. And for other common type of cancer screening, colorectal cancer, cervical cancer, for those type of cancer screening, it is difficult to observe overdiagnosis because screening itself reduces incidence by removing pre-cancerous regions such as colon polyps or cervical intraepithelial neoplasia. Another special example of overdiagnosis would be neuroblastoma in Japan or thyroid cancer in adulthood in Korea, but I will explain only for neuroblastoma cases. Neuroblastoma is a cancer for children, and screening at age 6 months using urine sample has been conducted since 1985 in Japan. In 2002, randomized control trial for evaluating this screening conducted in Canada and Germany, and they did not show reducing mortality and cause overdiagnosis. Then next year, Japanese government decided to hold the screening. This is what happened for incidence, neuroblastoma incidence, after cessation of the program. As you can see, incidence sharply declined after the cessation, and this is good for age group 0, but later age like 1 to 4 or 5 to 9, we expect somewhat increasing trend, but but it never happened actually. This is mortality. If the screening is effective for reducing mortality, after stopping screening, mortality should increase somewhat, but it never happened. Then, what this part of cases means, I think it is a concrete evidence for overdiagnosis. So this graph shows the proportion of population affected by screening findings, while only small part of a population affected by lethal region. Proportion becomes wider, larger and larger, and the region becomes earlier and earlier. Therefore, it is very important to assess the magnitude of overdiagnosis quantitatively. But still, the method is immature. In order to quantitatively evaluate the overdiagnosis, we need to investigate incidence in unscreened reference population, but it is not so easy to obtain appropriate references. Also, we need information for real time, and we still need some progress how to deal with these two key factors. So, as a issue on cancer overdiagnosis, I summarize like this. So, overdiagnosis is one of the most important harms caused by cancer screening, but it is still under progress to certify methodology how quantitatively evaluate the magnitude of overdiagnosis. And lastly, since overdiagnosis is difficult to recognize as harm, not only for laypersons but also health professionals, special effort are needed for explanation. Thank you for your attention.